It was in September 2005 when I discovered the lump that was to turn my world upside down. My GP organised a fine needle biopsy to be undertaken by a radiologist, but when the results came back within 5 days, it wasn't good news. Prior to surgery, I undertook nuclear medicine tests to identify the sentinel lymph nodes. These were the closest draining lymph nodes to my breast tumour and would also be removed. Pathology following surgery indicated that the tumour hadn't spread to the surrounding tissue, nor were there any cancer cells in the sentinel nodes. I was diagnosed with HER2-positive breast cancer, a grade 3 tumour. HER2-positive breast cancers make too much of the HER2 protein, which sit on the surface of cancer cells and receive signals that tell the cancer to grow and spread. These breast cancers tend to be more aggressive and harder to treat than others. The clinical team of the surgeon, oncologist, and radiation oncologist studied the test results and together worked out my care path. They would work as a team to give me the best outcome possible. I had utmost faith in their expertise, knowledge, and experience. My treatment consisted of AC chemotherapy, a combination of adriamycin and cyclophosphamide, a 30-cycle course of radiation therapy, and a new targeted drug, Herceptin. At the MDT clinic, I was warned my lung could be burnt by radiation, my hair would fall out, and I'd need a cocktail of additional drugs to combat the nausea of chemotherapy. Unfortunately, I was not in a strong emotional state to comprehend how my therapy would impact on my life. But on reflection, how can one be? I knew a little about chemotherapy. I had no knowledge regarding radiation therapy. I wasn't given any written information about the 3 treatments, nor specifics regarding therapy-induced side effects. I was a passive recipient of information given by specialists who were trying to put a positive light on the treatment regime that would lead to a successful outcome. I really suffered during chemotherapy. My hair started to fall out in the 2nd week, my weight dropped to 40 kilos, I had massive ulcers in my mouth, and I thought I would lose all my teeth. Having survived chemotherapy, I felt the following treatments would be a breeze in comparison. My 6 weeks of radiation therapy were not too physically or mentally taxing. The only noticeable side effects during treatment was burning of the skin and tiredness. I was not so fortunate with the Herceptin therapy. I proceeded well on the drug for about 6 cycles. Every 3 cycles, I had to have a nuclear medicine test to determine if the drug was affecting my heart. In the MUGA scan, a tiny amount of radioactive material was injected into a vein in my arm. This material temporarily hooked onto my red blood cell. A camera that could detect the radioactive material took pictures of the blood flow through my heart as it beat. The test following my 6th cycle revealed that my heart was being affected. I was given a 3-cycle break to try to recover good heart function. I was physically exhausted through lack of sleep because of the raised adrenaline level I was experiencing, which was trying to keep my heart from pumping. A few years later, I started to experience further symptoms from my cancer treatments. I was at a shopping centre when excruciating pain travelled from the base of my esophagus upwards towards the back of my throat. The staff at the centre immediately thought I was having a heart attack since I fell to my knees with the severity of the pain. After 5 or so minutes, the pain passed. The same symptoms happened again several times. An endoscope examination by a gastroenterologist revealed that my esophagus was rigid in sections. He believed that the stiffness was caused by the radiation therapy. On his advice, I've had to adjust my diet so that I don't eat solid, dry foods that can cause my esophagus to spasm. A new symptom emerged a few years ago. I would be involved in an activity and then I would suddenly faint. It is believed that my heart muscle has been affected by the AC chemo. Adriamycin drugs are most commonly linked to changes in the heart muscle. I undertook vascular surgery to improve the blood flow to my heart. As further side effects develop, I have learned to treat them or modify my life. I've undergone extensive dental work as the chemotherapy affected my tooth enamel. I have lost strength in my hands. This means I can't drive for long distances, so I walk or use public transport. Each cancer patient has a different story. Survival rates for most cancers have improved over the past decades. Highly tailored, more effective treatments have been developed to target different cancers, providing better cancer control and fewer side effects. However, improved survival rates have resulted in many patients having to live with a legacy of treatment side effects and the impact on their quality of life. Like all other cancer treatments, radiation therapy often causes side effects. These are different for each person and depend on the type of cancer, its location, the radiation therapy dose, and the patient's general health. Most people will have some mild side effects during and just after treatment. Radiation therapy is an integral part of cancer treatment, with more than 50% of all cancer patients receiving radiation therapy at some point in time. As more people are surviving cancer and living longer, knowledge about long-term side effects of treatment is expanding. One of the important late side effects of radiation therapy are radiation-induced second malignancies, RISM. Many factors contribute to their development, such as age at radiation, dose and volume of irradiated area, type of irradiated organ and tissue, radiation technique, and individual and family history of cancer. This is of growing concern in oncology because of the increased number of cancer survivors, and efforts are being made to prevent or decrease the incidence of RISM. Radiation therapy contributes to about 5% of the total treatment-related second malignancies. However, the incidence of only radiation on second malignancies is difficult to estimate because there are multiple factors to predispose the patient. As children and young adults are likely to survive for longer duration after anti-cancer therapy, they are at a greater risk. For a given dose, children are about 10-fold more sensitive to develop RSIM as compared to adults, and women are more prone to develop a second malignancy as compared to men. Use of older radiation techniques have been shown to increase the risk of RSM. As of now, there is little information available about those factors which can be modified to reduce the risk. There is a need for integrated research involving clinical studies, radiobiology and physics to estimate and reduce the risk of treatment-related second cancers. Cardiotoxicity, problems in the heart and vascular system, can develop within days or months after radiation, but often develops years later. Cardiotoxicity can reduce the patient's quality of life and increase the risk of death from cardiac-related causes. Cardiotoxicity is a risk when a large volume of heart muscle is exposed to a high dose of radiation. Radiation can injure the pericardium, the tissue covering the heart, myocardium, the heart muscle itself, the heart valves, coronary arteries, and the heart's electrical system. It is becoming clear that the longer a patient lives after cancer treatment, the more likely that damage to the heart will develop. Patients who develop radiation-related cardiotoxicity should be under the care of a cardiologist who understands the relationship between cancer treatment and heart problems. Although cardiotoxicity can be life-threatening, many of these problems can be managed effectively with medication and minimally invasive treatments. Radiation-induced fibrosis is a long-term side effect of external beam radiation. Radiation therapy can cause an increased production of fibrin, which makes the tissue less stretchy. Fibrin is a protein found in the body that accumulates and causes damage in radiated tissue over time. How this affects the patient depends on which part of the body was treated. Fibrosis may cause the bladder to hold less urine, the breast to feel firmer, the arm or leg to swell, breathlessness due to the lungs being less stretchy, and narrowing of the esophagus, making it difficult to swallow. Radiation-induced fibrosis involves rapidly and aggressively in some patients, where it develops gradually even years later in others due to complex, poorly understood mechanisms. It is a potentially painful, lifelong condition as the tissue changes are permanent. For patients with established radiation-induced fibrosis, treatment is primarily symptomatic. There is a real need for ongoing research to find therapies that can prevent formation of fibrosis or to treat the disease. Prevention is focused on improvements in radiation therapy techniques, which have resulted in high doses to the tumour target and decreased doses to normal tissue. The dose of X-rays or radioactive materials used in nuclear medicine imaging can vary widely. In general, the dose of radiopharmaceuticals given is small, and the patient's exposed to low levels of radiation. The potential health risks from radiation exposure are low in comparison to the benefits. In my case, having a sentinel node scan meant that only 4 nodes were removed during my surgery. The procedure left the other non-involved functional lymph nodes intact. It allowed critical treatment insights with the least possible surgery and trauma. It also meant that I had a much lower risk of developing lymphedema. The main goal of cancer treatment is to extend life, but the quality of that extended life is also important to the patient. The researcher, doctor, and patient team needs to embrace physical, mental, and emotional health and incorporate quality of life in consideration of the treatment options. The World Health Organization has noted that the main goals of cancer treatment are not only to cure or prolong patient lives, but also to ensure the best quality of life possible for the patient. Some patients don't care how much a treatment affects quality of life. They want to fight to get to a particular milestone, even if their quality of extra life is poor. For others, quality of life is just as important as length of life, or maybe even so. The risks and side effects from radiation therapy need to be effectively communicated to the patient. Frequently in the culture of doctor knows best, the cancer patient trusts their doctor to do what is appropriate and doesn't discuss the attendant risks. However, cancer patients need to be informed of the risks and known side effects prior to treatment and should be given the opportunity to discuss the matter in more detail with the treating specialist. They must be allowed to analyse the benefits against the risks. If the patients are able to review the side effects, they can decide if they can endure the effect or not. They should also be made aware of how common they are and options of managing the side effects. Providing cancer patients with information helps with decision making, prepares them for treatment, and helps with managing adverse effects associated with it, reduces anxiety and depression, increases satisfaction with treatment, and helps to improve their quality of life. Having had a recurrence of cancer last year, I approached my diagnosis and therapy in a more informed, objective manner. During the diagnostic tests, I asked the radiologist to give me the exact facts and not try to sugarcoat the results. The information provided reduced my uncertainty and therefore relieved my anxiety and stress. I was involved and treated as an active participant in the decision-making by every member of the treatment team. It is crucial that the specialist identifies and addresses the information needs of cancer patients in order to help them make decisions and cope. To support understanding by patients, the creation of patient-centred resources regarding radiation treatment and possible side effects are needed. Written information allows the patient to reflect on what will be involved during the therapy, enables an accurate understanding for discussion with family and friends, and becomes an excellent reference for managing both short-term and late onset therapy-induced effects. Radiation therapy techniques have changed significantly over the past few decades thanks to improvement in engineering and computing. Major advances in radiation therapy have made it more precise, reducing side effects and improving cancer control. Current techniques such as conformal radiation therapy and intensity modulator radiation therapy accurately shape the beam to fit the cancer. There is integration of imaging information in every phase of the treatment, from simulation to planning to delivery. These advances mean less healthy tissue receives radiation, reducing the risk of side effects. CT, MRI and functional imaging such as PET provide definitive imaging before treatment, allowing a more accurate assessment of disease spread and more effective treatment planning. 4D CT is becoming available in the clinical setting. Advances in the capability of linear accelerators enables the delivery of high-dose treatment to tumour cells while sparing tissue that is healthy. Treatment imaging allows the clinician to correct for patient movement, internal organ movement, and change in tumour size, enabling a personalised treatment, while advancement in the treatment counts can correct for pitch, roll and yaw, resulting in a more accurate and reliable patient treatment setup. This ensures consistency between planned and delivered treatment. At one time, radiation therapy was delivered in large fields with a static dose. Now IMRT allows the radiation dose to conform more precisely to the three-dimensional shape of the tumour by modulating the radiation beam into multiple smaller beams. What will radiation therapy look like in the future? In Australia, radiation therapy research is looking at ways to make radiation therapy more precise, effective and affordable. And I'd like to thank Professor Paul Keel for the following slides. Artificial intelligence in healthcare will complement doctors, offering several advantages by assisting doctors in making better data-driven decisions. AI can help improve the efficiency of diagnosis, management, administration and treatment. It will improve imaging and delivery to ensure consistent treatment for all cancer patients. It will promote adherence to clinical guidelines and standards, as well as improve cancer detection, precise targeting of the tumour, and improve the overall quality of treatment. Using artificial intelligence will allow the treating doctor to increase the time spent with the patient in consultations and doctor-patient interactions. MRI Linacs will help visualise and target the tumour during treatment, allowing greater precision in cancer treatment. This new technology enables the treating specialist to see where the radiation dose is being delivered and keeps the radiation directly on target. It will increase patient and treatment team confidence, knowing that the tumour is being precisely targeted, maximising the chance of the best possible outcome for the patient. As the human body is a dynamic system, tumours move during radiation treatment. There are several solutions for real-time targeting being developed. Kilovoltage interfraction monitoring, KIM, is one of the technologies being clinically pioneered in Australia to turn today's standard linear accelerator into tomorrow's real-time cancer targeting system. It is purely a software solution. As the human body, Today's radiation therapy cannot easily adjust to movements of the tumour that occur between imaging and the treatment phase. These movements cause mistargeting of the tumour. In the KIM system, radiation therapy dose hits the tumour and voids sensitive to surrounding tissue. At this stage, KIM has only been used for prostate cancer patients. However, a TROG trial will investigate this technology for other tumour sites. The global cancer burden is increasing. There are large access gaps to cancer care, especially in low-income and middle-income countries. Radiation therapy is a central component to the management of cancer worldwide. However, the disparities in its access are one of the largest technology gaps in healthcare today. Many patients in the world have no opportunity to access radiation therapy in their countries. Rethinking cancer treatment system designs with the patient experience, safety and costs in mind may improve global access to radiation therapy. 3 designs are under development at ICRP Imagex Institute. The first picture shows a horizontal treatment system. The prototype is at the Prince of Wales Hospital. The centre picture is an upright system, and the third is for proton therapy treatment. Overall, there is significant reduction in costs for manufacturing all 3 machines and a reduction in the size of the room needed for housing the equipment. Radiation therapy will increasingly be used in the oligometastatic setting, given the positive results of several clinical trials. In some situations, metastatic cancer can be cured, but most commonly treatment does not cure the cancer. Treatment can slow its growth and reduce symptoms, and is possible to live for many months or years with certain types of cancers, even after development of metastatic disease. A randomised clinical trial of targeted high-dose radiation therapy for men with oligometastatic prostate cancer has shown the treatment to be an effective and safe option for patients who wish to delay hormone suppressant therapy. The phase 2 trial found that radiation therapy can generate an immune system response not previously believed possible in this type of cancer. The Oriole trial has shed light on what happens to the immune system when the disease is treated with high-dose radiation therapy. The research team looked at blood cells sampled before radiation therapy 90 days after treatment. They found significant measurable changes in the T cells of patients on the SABRE arm, but no change in the T cells of those in the observation arm. This suggests that radiation therapy may spark the immune system to more aggressively fight the cancer. As radiation therapy is needed by approximately 50% of cancer patients in their treatment journey, there needs to be ongoing research to ensure that radiation therapy effectively targets the tumour and minimises potential side effects. As a cancer consumer advocate, I emphasise the importance of patients being informed of its risks, both short and long term, along with those of other cancer therapies, to enable the patient to be an active participant in their treatment path.
Lee, thank you very much indeed for sharing your story with us. In fact, we've had a comment from the audience that's been endorsed many times that says, "Thank you for sharing your story. You're a very brave lady." So, thank you. We have got a question here, and then we'll maybe open to the floor a little too. So, the first question is, with flexibility for justification of investigations, this has resulted in controversies. For example, the refusal to maybe screen a young patient who was then later diagnosed with a breast cancer. And do you agree that this would present a concern for patients if they're refused a screening study?
So the young patient's refusing to have breast screening?
No, that a young patient was refused screening and then was later diagnosed with cancer.
Well, unfortunately, there's more and more people that I've come into associated with that, are getting breast cancer, and I know some in their teenage years. So, I mean, I think the GP should be the first person involved in that, if there is a suspicion or a family can, particularly with genetic cancer, screening should start as early as possible. I'm very concerned. I have a daughter, and I was, read everything I know, because the incident of family's genetics, of course, would be a risk for her. HER2 positive are not, genetic, but even at that stage, my daughter's she's 33, she's starting screening at 35. She will pay for it, and to me it's a payment that's worth paying. As far as health, the Department of Health with free breast screening, I can understand statistically there is a date, a 50-year-old, but if you suspect that you could have a cancer or your likelihood is high, I think that it's a cost that you're going to bear as a patient. We would like to think that it was covered by the health department, but there's limited funds. But I do urge screening for all sorts of cancers. It's a very difficult situation, but if there's someone feels that they are a candidate for cancer, they should definitely be screened.
Okay, thank you. I think, again, obviously the situation's different in different countries, but your answer covers most of them. There's one more question here. You described yourself as passive before and during the first round of treatments.
Yes.
What could or should the medical team around you have done differently to improve your experience?
Yes. Well, my treatment was in 2005, and I assure you it's far better today than it was then. I had outstanding clinicians. They're all professors, really knew, and I knew I had a very confident thing. But when I went into that first meeting with the team, I went from specialist to specialist, it really would have helped me to have had just even a take-home sheet that I could actually look at. I was in a very emotional state. My husband was in a worse state than me. He was my carer, and I was more picking him up than he was picking me up. So I think that a document, today we've got computers, but in 2005, really, Dr. Google wasn't a big thing. And if I could have gone home and read about it, I know more about HER2 cancers than I did then. I suppose I didn't need to be told that my chances were very low. Before Herceptin, a lot of people were dying within 3 to 5 years with that sort of tumour. But take-home information really helps. But what would really help me is for my clinicians to give me more specifics about side effects that were going to be late onset. The short-term things are fine because you're still with the doctors, but I had stopped seeing my oncologist 5 years after my treatment finished. I was still seeing my surgeon because I'd lost my GP, and he'd said, no, I'll keep you on an annual basis. So I was sort of navigating by myself, and she never told me that, adriamycin drug is very, very dangerous to the heart, and they knew that then. It's not as though it was a new thing. So I think that sort of would have helped me a lot. I would have managed my life a lot differently. And I would have known to go and get treatment much earlier.
Thank you very much indeed for your contribution. Thank you.